Well, hi there. It's good to see you right here on Health Diary. My name is Winnie Lubembe, and today we're coming to you from Kenyatta National Hospital. On the show, we'll be talking about postpartum hemorrhage or excessive bleeding after delivery. The biggest question is, what exactly is postpartum hemorrhage? Who is at risk of the same? And is it even possible to eliminate deaths from postpartum hemorrhage? Well, we'll find out after this fact of the matter.
Postpartum hemorrhage, or severe bleeding after childbirth, is the leading cause of maternal mortality worldwide. Each year, about 14 million women experience postpartum hemorrhage, resulting in about 70,000 maternal deaths globally. Even when women survive, they often need urgent surgical interventions to control the bleeding.
So the World Health Organization reports that about 14 million women, and this is globally, experience postpartum hemorrhage. So the big question is, what exactly is postpartum hemorrhage and what do the numbers look like right here in the country? Well, we have Professor Moses Obimbo, who's a consultant obstetrician gynecologist to help us really understand the depth of postpartum hemorrhage. Dr. It's so good to see you.
Thank
you so much for sparing the time. You know, you could be out there bringing babies into the world. So thank you for making the time. And we also have Mariana Muchiri, who's here to share her journey as far as postpartum hemorrhage is concerned. Mariana, how are you doing?
I'm doing well.
I see there's a theme. There's something going on. Daktari has a bit of kwa socks yake. Ukiangalia vizuri, you will see.
Yeah.
But it's good to see you both right here. So can we just start with postpartum hemorrhage? Such a big word. So let's bring it home a little bit and understand what it's all about.
Thank you for having us on this show today. And just simply by defining what postpartum hemorrhage is, it's simply defined as excessive bleeding after childbirth.
Okay.
And it can happen within 24 hours of childbirth or later on after between 24 hours and 12 weeks. And the definition of excessive bleeding is getting out about 2 packets of equivalent to milk packet per that vaginal delivery or cesarean delivery. That's what the definition of
Postpartum hemorrhage is.
And sometimes some people can lose less blood than that, but still have the symptoms such as dizziness, heart beating faster, or fainting. Although they have lost less blood, that will still be defined as postpartum hemorrhage.
I see. And you see, during delivery, so there's a lot of things that is happening. The baby is coming to the world, you know, the baby is crying, the mother has just delivered. Like, there's a lot of things that are happening. Is it easier to notice a case of postpartum hemorrhage, or does it take, a while? Because there's a lot of things happening, but sometimes it can be missed, no?
Yes, at the time of delivery, there are quite a number of things that are happening because you've delivered the baby. The baby is being supported by the neonatal team. You're also delivering the placenta. And as you're delivering the placenta, you might notice that there is excessive bleeding at that particular time. But sometimes you don't notice this excessive bleeding until the patient's gone back to the hospital bed and then they discover the patient's all overweight. So we have protocols by which we have to examine the patients post-delivery. And these protocols need to be adhered to so that you're able to identify and recognize these women who are at risk of bleeding excessively in good time so that enough intervention can be put in place.
And we'll talk about intervention a little bit later and just get to understand where we are at as a country. But so the numbers that we have, is the global figures. In the country, do we have numbers just to paint a picture of where we are at?
We have some numbers in the country. And based on what we define as postpartum hemorrhage numbers, and are picked from the registry. And quite a number of women, about 2 to 10% of pregnancies in various counties would be affected by postpartum hemorrhage. And so if we have about 1.5 million deliveries every year, about 150,000 women, in one way or the other, will suffer from postpartum hemorrhage. And a number of them will die because of postpartum hemorrhage.
And it's something that can be prevented.
It's something that is
should not
preventable
be
and treatable and should not result into death.
Absolutely. We'll come back to understand, because like you said, there are women at risk. So what exactly does that risk look like when we're talking about excessive bleeding after delivery, right? But Mariana, so you have a 2-year-old right now. First of all, how are they doing, boy, girl?
Thank you very much, Winnie, and for the opportunity. He's a boy.
A boy.
Yeah, a 2-year-old boy, and he's now very active, playing all over, playing football. And when I get home, he gives me a lot of joy.
It's the best thing.
Yeah, the best thing that's happened to me.
I
Yeah.
can imagine.
Yes. Yeah.
Okay, so going back.
Yes.
I mean, before him,
Yes,
it wasn't easy.
yes,
There has been a lot of losses
Yes.
happening.
yes.
Again, to a level that you're comfortable to share. Take us a little bit back.
Yeah, so allow me to take you back to 2020, January 14. I delivered twins, very beautiful twin girls, albeit them being delivered preterm. And this was attributed to high blood pressure, preeclampsia, eclampsia in pregnancy. So I went into labor at 28 weeks, and unfortunately, they had to be delivered and put on life support. They survived for 2 weeks, but they also got to a point where they got some neonatal infection and they succumbed. Both of them succumbed. But in 2021, so that really took a toll on us as a family because we had already done shopping for the babies and we were expecting them at home. But we realized that we were going home empty-handed, yet we had gone to the hospital expecting to come home with babies. But that went through and went back home and just mourned the baby.
Yeah.
And we rested them in February the same year. Then after that, we conceived again in 2021. Unfortunately, the same challenge recurred. And in August 2021, I lost another pregnancy. Yeah, so that was quite traumatizing because now we really hoped that we would survive the previous traumatic experience. But now we later discovered that now the pregnancy was lost. Then in 2022, January, God blessed us again. And at 6 weeks, I started bleeding again with the pregnancy of the 2-year-old now. And the bleeding really persisted. And when I was rushed to the hospital, it was actually a chance of survival because when I was taken to the hospital, the bleeding was too much. And one of the healthcare providers really doubted whether the baby would survive. So my consultant gynecologist just indicated to the care team if they could just give it a benefit of doubt and do a scan at 6 weeks. And when the scan was done, the doctor was able to pick the heartbeats. I clearly remember the heartbeat was around 142 beats per minute. And that really gave us hope. And from then, the doctor noted that my pregnancies were high risk and he needed to take good care of me. And he was always available for me. Whenever I would experience any challenge, I would call him. And I was able to go through the pregnancy safely, though with on and off bleeding midway. At 37 weeks, when I was expecting, for example, to deliver in the next 2 weeks at 39 weeks, my waters broke again. Remember, this is a pregnancy that was really handled with a lot of care, with a lot of professionalism. I got all the support I could get from the healthcare providers team. But at 36 weeks, my waters broke. My waters break and I'm alone in the house and I needed somebody to rush me to the hospital. So when I called my doctor, indicated to him that my waters had broke, and considering the earlier bleeding, he put something that they call a McDonald's stitch, just to protect the baby and to ensure that I'm able to reach term pregnancy. So it was a pregnancy that was very delicate. So when waters broke at 36 weeks, I just gave him a call and told him, Daktari, there's a problem. My waters are broken and I have a McDonald's stitch. What do I do? And he told me, just come to the hospital. I'll be waiting for you.
All right.
And when I reached the hospital, the team was ready for me. They rushed me into the theater. It was an emergency CS because now I had drained all the amniotic fluid. And remember, it's a baby that is so precious that we really looked, we really needed to handle it. Yeah.
Whew, that's a lot. Can we take a break to just absorb everything? And then when we come back, we'd want to hear. So you got into the hospital.
Yes.
Everybody was waiting for you.
Yes.
Seems like everything was in order, but something
went wrong.
Right?
Yes.
Okay, so we'll address that. And then the whole question about, is it possible to completely eliminate deaths from postpartum hemorrhage, and how we're doing as a country in terms of the management of the same. And all that is coming up after the break. So do stay with us. The show is Health Diary. Welcome back to the show. Today on Health Diary, we're focusing on postpartum hemorrhage or excessive bleeding, and this is after delivery. And Dr. pointed a picture that I'm pretty sure we can all relate to, and that is, think about 2 packets of 500 ml of milk, okay? So that, equals to 1,000 or 1 liter. So that amount of blood is sometimes lost. Or it could be more, Dr. right?
Yeah.
It could be more, during delivery. So think about the mother, at that point. And that is why this conversation is very, very important for us to have today. And we have Professor Moses Obimbo, who's a consultant obstetrician gynecologist. I have to say it very slowly. And we also have Mariana Muturi, who's here to share her journey as far as postpartum hemorrhage is concerned. So Mariana, we left at a point where, so you got to the hospital, everybody's waiting for you, everything seems to be, going in order.
Yeah.
What went wrong? What happened?
So the conversation around me was, first, do we remove the McDonald's stitch or do we deliver the baby?
Okay.
Because now I had drained all my amniotic fluid and there was a risk of the baby getting an infection and probably developing some breathing challenges. So they decided to first remove the stitch and then deliver the baby. When the baby was delivered, I couldn't see the baby because they were rushed to the neonatal unit because they were not breathing. So he required a lot support, full life support, because he was put on a ventilator. And he was in that ventilator for 2 days. But after delivery, I realized that I wasn't being released to the ward immediately. And when I asked why I'm not being released to the ward, I was told I needed it to be managed. I needed to be managed. Later on, that's when I realized that I was actually bleeding seriously, and that bleeding needed to be contained because I had 2 previous scars from CS, and apparently I needed to be managed well so that I don't lose a lot of blood. Yeah.
And Doc, so there's the bleeding during, and after delivery, but there's also bleeding during pregnancy.
Yes.
Yes.
Yeah.
So these are 2 different forms of bleeding. There's one that you're bleeding before you deliver.
Yeah.
That we call it postpartum hemorrhage, or excessive bleeding before. It's very dangerous because the placenta is in the wrong place, or the placenta separated early, and if that's the cause, then it needs immediate attention. Otherwise, then it can translate into possible fetal loss or maternal loss. So that's antepartum hemorrhage. Then there's now bleeding excessively after giving birth. That's the postpartum hemorrhage, which you've already defined, and you've already also seen some of the risk factors. But to also just put in context, postpartum hemorrhage itself as one of the causes of maternal mortalities in this country, it accounts for about 40 to 60%. In some counties, as high as 60. In some places, as low as even 35. But that's a big number.
That's a lot.
So if you're losing on average about 5,000 in this country every year, about 3,000 women we lost every year because of postpartum hemorrhage. And if count terms of days, it means every day you're losing between 7 to 10 women.
That's a lot. That's a lot,
completely preventable, completely treatable. And so there is so much that we already know in terms of science of postpartum hemorrhage and how it happens and what should be done. Then there is also, as clinicians, the protocols that we know that, we should be able to address and treat patients who are at risk of postpartum hemorrhage and patients who develop postpartum hemorrhage when they are under our care, so that no woman is lost. But then the question should always be, what don't we know? The question should always be, what are we doing with the information that we already know? So it turns out that there's not so much that's known around by the public and the communities that we take care of about excessive bleeding.
And for a case of secondary PPH, I'm just trying to wonder the managers, because I want to believe, again, everything that's needed to be done would have been done after delivery. But then, say, like a case of 2 weeks later, what does the management then look?
So the management, when we discharge mothers from our units after 2 days, or 2 days normal delivery, 3 days after cesarean delivery, we explain to them the danger signs when they go home.
Okay.
So we tell them if they notice there's foul smelling discharge, if they're dizzy, and if they bleed excessively, if they start noticing that the bleeding has stopped, but now they have to change pads when they're at home, they have to come back to the hospital immediately. And then, once they're in the hospital, we institute routine management protocols, because then we need to check what's causing this bleeding. So you have to identify, is it that we have a fibroid within this uterus causing the bleeding? Is it an infection that's causing this bleeding? Is it a tear that was not picked that's causing the bleeding? So we institute the protocol to manage this woman. Most important thing is recognition, and self-recognition. That's different from the hospital recognition made by the doctors.
I see that. And Mariana, you're very passionate about talking about this and just passing information, out there. So as we bring this to a close, what is it that, and having gone through it, what is it that you feel either the communities, people, everybody who's watching us, number one, need to know? What is it that maybe healthcare providers, could do better, and what is it that governments, would do better, and especially when it comes to treatment cost, and we all know how the cost of care in the country is a bit expensive, right? So what is it that you want people to know based on your story and based on your journey?
So in terms of my message to the people, one, awareness is very important, because like I mentioned earlier, my pregnancies were high risk. So when I conceived my 2-year-old in 2022, one of the things that the doctor did was to put me on what we call multiple micronutrients care. So prenatal supplementation before even conceiving. So just taking care of the nutritional requirements of the woman, so that even the pregnancy becomes very smooth to the end. Then number two, I need to mention that continuous antenatal care, if possible, up to the entire period of the pregnancy for pregnant women, because every month or every 2 months, my consultant gynecologist would be able to just see me, check out and do the ultrasounds and check whether the baby is fine, whether the pregnancy is progressing well, and pick issues that would arise during the pregnancy. So continuous monitoring through antenatal care during the visits, I think, is very critical. Then having trained team, well-equipped healthcare providers in the facilities, because I found that was very, very helpful to me as a patient, because at that time I was very vulnerable. I was fully dependent on the team that
can't
was
even
there.
advocate for yourself because
I'm at a disadvantaged position, but the team that I got in that hospital was well-trained, they were well-equipped, and they had all the commodities that were required just to manage. And given they had my history of pregnancy losses, miscarriages, and the preterm delivery of the twins, I think gave them a kind of an alert system, and I think that really helped. Then in terms of policymakers, just availing resources to ensure that the healthcare providers are well trained, the commodities that are required for PPH management and prevention are available at facility level, and the community has a mechanism through which the knowledge can be transferred across the different settings. And probably the community health strategy could come a long way in ensuring that awareness is created amongst mothers to ensure that even the mother in the village knows the danger signs, and they can just rush to the hospital or give a call to the doctor, and they can get help.
Thanks, Mariana.
Yes.
Very, very powerful insights.
Yes.
And Doc, so unfortunately not hospitals are equipped. Like Mariana said, all the communities from commodities, equipment, human resource, as well. So maybe speak on that a little bit. And then also, like we said, so home births is like the new thing. All women want to, okay, not all, most women want to give birth at home. People have their own doulas, and also with midwives, and even those communities where traditional, they were called what?
Birth attendants.
Yes. Would help. So what is it that you'd also want to speak to that, and on a larger scale, really, what we can do as a country?
Yeah. So as a country, I think we moving towards universal health coverage, health care for everybody.
Yeah.
And what defines communities' health is women's health, and most importantly, maternal health.
Maternal health.
So if we have poor indicators of our mother's health, then we are really doing badly overall. So that's all getting to aspect of universal health coverage. We need to prioritize resources towards women's health.
Yeah.
Now, everybody's born of a mother. And mothers determine who we are as a generation, not just now, but the future generations as well.
Yeah.
So we need to take enough investment, not just in the women who are pregnant at this particular time, but with the growth spectrum of a woman's life cycle, from puberty, going to adolescence, and going all the way to teenage adult, because their health will then determine how that pregnancy goes, and then that pregnancy will determine the future generation. So we need a lot of resources invested in the healthcare programs, and that's why we are amplifying all these voices, and only great heroes will be fighting for mothers. That is very important to have this women's health respected. The other issue that we've been talking about is the issues of home delivery. As you can see, sometimes very unpredictable. You tell who goes and has complication versus who will have normal pregnancy. So large and by, many women deliver and it's uneventful. It's okay. It goes very well.
Yeah.
But you can also see that those risks, high blood pressure, sepsis, complications resulting from obstructed labor. And sometimes you're not able to tell that this would happen to you by the home delivery. So you might have a delivery, or you might have a midwife assisting at home. But if you do not have enough resources in that environment to take care of these complications, then it's really a risky undertaking. And my take is, unless you really have a hospital set up at home, I think then it's unwise to have that kind of a risk, and would encourage all women to access hospitals for care. And then ours is to amplify the voices, make sure that the government invests enough resources to take care of our women, take care of our mothers, so that no woman dies of preventable and treatable process.
I really like that. Strong point to end the show, but I really want to ask this. So for someone who has had a risk of postpartum hemorrhage, and again, the one conceived, right, later on, what does that look like to prevent?
Yes. So it's important that if one has a risk of postpartum hemorrhage in the previous pregnancy, then the likelihood of them having a repeat hemorrhage or excessive bleeding is higher.
Okay.
So this will be considered as high-risk pregnancies, and they need to be managed as such. So they will need to be at the hospital care. Then for us, we'll need to make sure that we have the products that are important in prevention of excessive bleeding, the medications plus the blood. So we are prepared. So sometimes they go and have bleeding, which you manage. Sometimes they do not have, but it's better to get prepared for such a woman, because then we know she's already at high risk of bleeding excessively.
I see that. Thank you so much, Professor. Professor Moses Obimbo, who's a consultant obstetrician gynecologist, and as well as Mariana Mutre. Thank you so much for your time today. Insightful conversation that we had. And I'm happy, Dr. that you're saying this, and this is, it can be prevented and can be treated. So there's no reason why we should lose a woman, to postpartum hemorrhage. Well, time now for you to take a look at this health tip.
This week on Health Tip, we are focusing on using emergency contraceptive pill, the Postino 2 or P2. So when using the P2, you need to use it within 72 hours of unprotected sexual intercourse. If you exceed that, it's likely to fail. And another reminder to put in mind is that you need to use it before ovulation happens, because it works by delaying ovulation. So if you use it afterwards, it may not serve you well.
Well, between 2 to 10% of women right here in the country are affected by postpartum hemorrhage. And in 2025, the conversations should be different. But the fact of the matter is we still have so many women lose their lives to postpartum hemorrhage. The biggest question is, what do we need to do better to improve the outcome of the same? Well, that marks it on today's episode of Health Diary. But stay tuned, because next week we'll be continuing with the same conversation, but we'll be speaking to a dad who unfortunately lost his wife to postpartum hemorrhage, and also look at the developmental impacts of postpartum hemorrhage to a child, a conversation that you do not want to miss. But until then, stay safe, God bless. My name is Winnie Lubembe, and a special thanks to Kenyatta National Hospital for hosting us today. See you next week. Well, hi there. It's good to see you right here on Health Diary. My name is Winnie Lubembe, and we're coming to you from Kenyatta National Referral